I forgot to mention that once the baby is out and on the mother, then what we as care providers and usually the midwives will do automatically is to give the baby K vitamin, and you will push on the uterus. So postpartum hemorrhage is 4 things, right? There's tone, which is uterine tone. There is tissue, which is the placenta, and then there's trauma, and then there's thrombin, like coagulopathies from maybe PE and DIC, preeclampsia and disseminated intravascular coagulopathy, right? So for the tone, that's in like 70% of all reasons for postpartum hemorrhagia, and then you'll put a hand here and then push down, and it's usually hurting for mama when you do this like almost right away. But only when like around the either when the placenta is not totally coming out or it's coming out and it has come out, then you'll just make sure that it's contracted, or if it's really bleeding a lot. All right, but once the baby is up there, then you'll just wait for a few pushes, and then usually the placenta will come out. You will not yank in the umbilical cord. You'll just gently have a bit of traction, and oftentimes with a towel or something for friction wrapped around the umbilical cord. Then usually it'll come up with the next or a couple of contractions, and you'll make sure that the placenta is whole and there's no bits missing, and that's important to do right away. Because if there's bits missing, then, and it's not always like that's not the best test to just check the placenta, but because sometimes there are bits missing. But once the placenta is out, then you'll check the tone and then just push up here, so like in, and you'll have the uterus in your hand and push, and usually you'll get bleeding, and you'll also often feel in the hand that it's contracting. The more births there's been, the higher risk of an atonic uterus, and usually you'll give oxytocin at this point as well for the mama for the same reason, oxytocin boluses. All right. Then if it continues bleeding and the uterus is well contracted, then you will consider, and you think that maybe the placenta hasn't come all the way out. If sometimes the umbilical cord breaks, then you'll check. Then you might get a hand in the vagina, and then with a sharp instrument try to grab the placenta and pull it out gently. But oftentimes you have to, if it's a smaller amount, then you have to go to operation and then scoop it out. Okay. For the tissue part, tissue is, for the trauma part, then the midwives will usually suture if there is a tear, and tear grade 1 to 2 are common. Then you use that's what you do right away. You usually do it in local anesthetics, maybe with a pudendus blockade, and usually spray first and then pudendus blockade, where you inject in like in and down, in and up, and in and right in. Maybe I think it's like 10 milliliters of silocaine at both here and here on both sides of the vagina, around maybe of the entire length of the vaginal opening. Then maybe I can't remember, maybe 1/3 up. Yeah, this might be wrong. Check it out. All right, and but if it continues bleeding, and so the most likely thing is always tonus. It's like 70%. Then the placenta, the tissue is like maybe 20%, and then the last 10% is like the trauma. But usually you'll just suture the trauma. So what you have left is coagulopathy, which is really rare, maybe under 1%. The thing is, if they're not known with coagulopathy, then it might be preeclampsia that may induce a DIC condition. So if they have preeclampsia, think about that. But otherwise, if they keep bleeding, and usually like there's a graded stepwise approach here, but if they keep bleeding, you will have to, of course, you have to measure it and weigh the bleeding, because it's easy to be mistaken by a small amount of bleeding for a long time, that can easily amount to over 1.5 liters. 1.5 liters is like a magical boundary where you really consider operation. So what you can do, either you can give. So when you think it's an atonic uterus, then you'll get uterine contraction drugs, methadone, and others. Usually there's a box saying what you can do, but also you'll do the contractions like that, and in and out, in and down. All right, and you get oxytocin. Those are probably the most important things for that. If you have a placenta that is then you go for operation. If these maneuvers that I just told you about didn't help. If you have a if you have a trauma problem, like you think it's just the bleeding but it's not stopping, and maybe because of dick, then you'll compress the vagina, and then you'll do that. Yeah, it's really important that the uterus is contracting. Sometimes there can be, if it's bleeding a little bit for a long time, then there might be clots in the uterus, keeping it from contracting. So you can imagine if there's a uterus that's full of clots. So it's really important to have this push, and then when you've had the push, then push it for a while and get the drugs, and then sometimes the uterus is really vascular, right? So sometimes it will just keep bleeding a little bit, and then at that point is a balance. You may just want to release until you know that it's contracted, because if you keep pushing, then it might keep bleeding as well a little bit. So there's a balance there after the clots have come out and after you've given the drugs for contraction. Yeah, there are some, in the rare cases, it doesn't stop bleeding, and you have to maybe do a hysterectomy. That's like really rare cases. And if the hysterectomy doesn't help, then you have to do an embolization, and hysterectomy is usually those things that you can do then. At some point, if you're going to operation, then you usually will give some kind of antibiotics as well. Okay. So that's probably what we should know about for these conditions. There's one final thought I wanted to mention, that just when the baby comes out and the mother's all of the fluid going to the uterus has to be redistributed. It's like a tsunami for the heart, and that's why in the next couple of hours to days they will be in high risk of DVTs. They will be their preeclampsia may develop. If it hasn't already, if they don't have preeclampsia, they may develop a bit of hypertension on the day 3 or 5, which is in isolation normal, and can be treated with labetalol or drugs like that. But if it's not in isolation, but it's with preeclamptic symptoms, especially just right after birth, then you'll have to monitor it and maybe give magnesium if they have severe symptoms. Yeah, I think that's it for the postpartum part for emergency physicians for now, and I'll see you again later.